for next week. Still, the class is getting smaller. I was worried that it will be a packed. Yeah, so I was worried that it will be a packed. It will be a packed class. Obviously, my work was hard. It's not in the right place, because I don't know whether it's the class. Anyways, we can continue now. All right, muscle biopsy. So this is for next week. You can see actually that there is two themes this week, which is joints and muscles. The reason for this is that my idea is that if you finish early, you will have more time to read for your exam, and you will not be jam-packed at the end of the block. So I apologize if you are jam-packed at the beginning. You have to do it somewhere. Either at the end or at the front. And it seems to me that at the front is easier because you will have more. You will be more relaxed at the end of the block, and this has been a complaint from, prior classes. So bear with us, if you feel that there is more than one thing during the week. But you can see also that, the theme is following what needs to be followed. So you started today with physiology in the morning, right?
Yes.
Physiology of the muscle, you got that? Good. So this is actually the pathology. Next week, inshallah, you will be doing the clinical in pathology. All right, so when it comes to muscle biopsy, it's an important part of the diagnostic process. When it comes to certain diseases, there are other diseases, in muscle disease, where you don't really need a biopsy. Why? Because you have a better actually tool to diagnose the disease, which is a PCR, a molecular tool such as the polymerase chain reaction test that is going to give you actually which gene is affected in a muscular dystrophy patient. So if it's a muscular dystrophy, then the need for the biopsy will be really diminished. Why? Because most of the diagnosis will happen using your PCR test. Okay, but there are other conditions where you will feel that the use of a biopsy is very much needed, and resorting to biopsy is very much needed. Why? Because there is no gene to look for that is going to be diagnostic for you. Now, when you look for a muscle to take the biopsy from, it's very important that you have a clinical impression about the disease. Why? Because you choosing the muscle is going to depend on you knowing the disease and the spread of the disease. If you choose a muscle that is not affected by the disease or unlikely to be affected by the disease, that will actually create a false negative result for you, right? So this is why you need to know the spread of the disease, and you need to focus on which muscle is affected by that disease so that you go after it, and hopefully you will be able to make the diagnosis. So this is the first consideration. The second consideration is that you need to choose a viable muscle. So if you have chosen a muscle that is fibrotic, or that has ended up as being replaced by a fibrofatty tissue, the end result again that's you're gonna get a false negative. Why? Because you don't see any muscle fibers actually to make your diagnosis on. So the muscle that you choose has to be a viable muscle, a functional muscle that hopefully will give you the diagnosis. What do you do other than microscopic examination? You need to actually do the histochemistry, and you may also do immunohistochemistry, such as the Duchenne protein that is going to give you the muscular dystrophy diagnosis. This is a list of the myopathies in general that you may find yourself having to diagnose. So, for example, inflammatory myopathies, we're going to be talking about a couple of them today. Those are actually most likely to be autoimmune in nature. The presumptive etiology is autoimmune in nature. Toxic, there is actually a starting point with alcohol or steroids. Endocrine, you will see that it is really strange that thyroid disorders, both hypothyroidism and hyperthyroidism, are associated with muscle disease and muscle weakness. There is a list of inherited disorders, including muscular dystrophies. This is something that you're going to be seeing actually next week, inshallah, in the PBL. So you're going to be trying to find out which of this list is going to be the disease in question. Congenital dystrophy, we're going to talk about it a little bit here today. And congenital myopathies, such as metabolic, such as mitochondrial and glycogen lipid storage. All right, starting with congenital abnormalities. So, this is a newborn will be having actually this set of conditions. Now, it's a non-progressive disease, so it will not progress, but the disease itself is horrible. One of my students, in the prior school before coming here, his baby daughter was born with this. It was a devastating disease. I cannot take her out of my mind. When it comes to the differential diagnosis about what disease you are dealing with, this is not really related to medical school, but I will summarize to you what you could go after. Most likely it's going to be a histochemical study where you will see that the enzyme abnormalities is going to tell you it's going to change actually the appearance of the muscle cell and will tell you actually what are you dealing with. It could be the presence of an abnormally placed nuclei, such as what you see with centronuclear myopathy. There may be disruption of the normal muscle fibers, such as what you see with central core myopathy. And finally, abnormal inclusions in the muscle fiber. Now, inflammatory myopathies, we're going to be talking a little bit more in this. Again, autoimmune in nature, heterogeneous group of muscle disorders. You will see with or without actually involvement of other tissues, such as the skin, such as what you see with dermatomyositis. And you will see that there is an involvement actually or association with malignancy, with malignant diagnosis in the adult population. So it is important to keep in mind because there is something that actually could be lurking behind it in the form of a visceral neoplasm. Major idiopathic forms include polymyositis, dermatomyositis, and inclusion body myositis. In terms of the epidemiology, it's more likely to be a female than male. Now, it has a bimodal distribution. You will see that happening again, actually, in other myopathies. So in this one, the first peak will be in the 10 to 15 years, and the second one will be in the 45 to 60 years. Again, remember the association between malignancy. This is a question that is a repeated question on different standardized examination. Between malignancies, visceral cancer, colon cancer, gastric cancer, and inflammatory myopathy, especially dermatomyositis and polymyositis. There's also association with the anti-Jo1, which is directed against the anti-histidine tRNA synthetase. All right, starting with polymyositis, obviously there is actually an involvement of multiple muscle, in this case, symmetrical involvement of the proximal muscle, most likely the neck muscles, in about 50% of the cases. That's important actually to keep in mind, also for your exam. The ocular and the facial muscles are almost never affected, also important. Distal muscles are spared in the vast majority of patients. There is association with dysphagia and dysphonia. And there is also association with other autoimmune manifestation of the disease, such as myocarditis, interstitial lung disease, or vasculitis. Here's an example of that, where you see that those inflammatory cells are attacking the muscle fibers, destroying it in the process, eating it up completely. Same exact thing right here, where you see that tumorous macrophages are actually gulping up the result of the destruction of those myocytes. Dermatomyositis is polymyositis add to it skin eruption in the form of violaceous erythematous eruption that could be over the knuckle with what you call a Guthrie sign, or actually over the eyelids in what you call heliotrope sign, or over the upper front, over the shoulders and the neck and the chest, and that's actually what we call the shallow sign. Now this actually has association with malignancy in about a quarter of the cases, and association with anti-M2. I'm sorry, the anti-Me2. Anti-Me2. Me is obviously, it must be actually an Asian name. And what you have here actually is important to remember this. Remember the Jo1 and you I'm going to actually be asking you about it in the exam. I'm saying this to you now, actually, this is a tribute for you being here at 3 o'clock on a Thursday. Usually I don't like it, and you don't like it either, but I'm happy to see you here. And remember that, these are two important points to be made. What are they directed against, and where do you find them? All right, metabolic myopathies. In this case, actually, it is a substance, that is defying degrading as a result of enzyme deficiency that is accumulating in several tissues across the body. In this case, the muscles is involved in this process. You see that with Pompe disease and McArdle disease as well. So, for example, with Pompe disease, autosomal recessive, the enzyme that is entrusted in breaking down the glycogen is deficient. The end result is going to be actually accumulation of the lysosomal glycogen in those cells, disrupting and destroying those cells eventually. Now, depending on how much deficiency you have, the severity of the disease will be related to that. So, less than 1%, 1 to 10%, and above, and about 10 to 40% of normal. The more that the enzyme is active, the less the symptoms are severe. And in those patients less than 1%, the death usually happens before the end of the first year of life, as a result of cardiorespiratory failure. Why? Because this substance is accumulating in the heart muscles and is destroying the heart muscle. It's also taking care of the respiratory muscles at the same time. All right, so now the start of today, which is going to be the neuromuscular junction disease. By the way, study it from this year's lecture. I took a lot of actually stuff that are redundant and stuff that you will see because I reviewed the clinical lectures as well. And like I told you, that redundancy should not be there. Again, if you have it in EPL, why are you reading it here? I will give you a clue, and that should not be the case because you should go home and you should do your homework when it comes to finding out the right diagnosis and the right management and everything about the PPL case. So if you see it, less than before, it is for that reason. Neuromuscular junction. I did a transfusion medicine fellowship in the US, and all my patients during this, I never had anybody else except neuromuscular junction patient, usually myasthenia gravis. Who is your patient? That's a very important actually thing to keep in mind. A middle-aged white female who comes in actually with reporting weakness, especially in the facial muscles. The weakness usually are in the extraocular muscles and the eyelid, facial and palatal muscles. You will see that the ptosis is a very frequent presentation. Ptosis of the eyelid is a very frequent presentation of those patients. Now, the weakness in this case is very characteristic. Why? Because the weakness is going to result from repeated use of that muscle. Okay, remember that. Very important to actually keep that in mind. And we will see why is that the case in the pathophysiology and the immunopathology mechanism in this disease. All right, so it is considered an autoimmune disease type 2 hypersensitivity with autoantibodies that are directed against the acetylcholine receptors. The end result is going to be a reduction of the acetylcholine receptors at the postsynaptic muscle membrane. And as a result of that, the safety factor, do you guys know what the safety factor is? Have you read it anywhere, physiology? Today you took a lecture in physiology. Let's see if you have gone over the safety factor. What is the safety factor?
Extracirculatory. Excessive or extracirculatory just to make sure.
Safety factor. This is what you call I call it, if you have another name for it, I call it reserve ability. Meaning, so let's say that you are using a certain muscle let's say in the face. Every time you're using it, you're spending actually acetylcholine, correct? So with this release of acetylcholine, you would expect that the next time there is a release of acetylcholine, you will have less of that actually being released. Even with less acetylcholine that is being released, the muscle will respond with actually depolarization and contraction. Okay? The loss of the safety factor will happen when you have less acetylcholine receptors. This is one. Two, you have, it may be actually due to the fact that the acetylcholine receptors itself are damaged. So either quality or quantity of the acetylcholine receptors. The end result is going to be that there is actually progressive weakness as a result of the repetitive use of those group of muscles. This is actually what could be labeled as loss of safety factor, and this is the reason why those patients actually present, with this kind of scenario with, progressive weakness resulting from repeated use. All right, so again, you see bimodal peak of incidence with first peak in the third decade and the second peak in the second decade of life. And it is the most common disorder affecting the neuromuscular junction. They did a study in Greece. They found out that actually the incidence is about 7.4 per million on an annual basis. And they found out that the point prevalence at one point in time was 70 on average between males and females. Now, what are the classification of the myasthenia gravis? Acquired autoimmune, this is actually the most common form. Transient neonatal, that's going to result from the passage of those autoantibodies in the placenta during pregnancy. And the drug-induced, there is a set of actually medications that may result in this. One of them is the diphenhydramine. The idea is that it's going to be very similar actually to the acquired autoimmune disease, except that when the drug stops, the hope is that you will be able to reverse, or the disease itself will actually be reversed and the patient will go back to normal. Now, there's also congenital myasthenic syndromes. We will see actually that, as a result of the detailed study of the AChR receptor makeup and structure, other diseases were also, were found that were related to abnormalities and some of the channels that you see, that are disrupted as a result of gene mutations in the components of the acetylcholine receptor structure. So this is actually the neuromuscular junction. Have you guys talked about it today?
Yes.
Yes.
In details, or?
Yes.
All right, so we can do it again. Let's see if you have missed anything, right? All right, so the presynaptic is the motor neuron, right? The postsynapse is the postsynaptic, part of the neuromuscular junction is the muscle fiber. Between them is the synapse, right?
Yes.
The synapse is the synaptic cleft, if you will, is actually two parts. The primary one right here and the secondary one right here. Now, in the presynaptic component of the neuromuscular junction, the acetylcholine is made up of acetyl, coenzyme A, and choline, and is packaged in vesicles, and those vesicles are going to be releasing their content upon the arrival of the nerve impulse. Now, for those vesicles to be able to do this, calcium has to enter them. All right, and where does the calcium come from?
From the endoplasmic reticulum.
From the sarcoplasmic reticulum.
So reticulum like بالنرف.
Can you raise your hand now? Go ahead, please.
From the sarcoplasmic reticulum.
Right, but there is something called calcium-gated calcium. What is it?
Sorry, what are you? What's your question?
I'm asking you, where does the calcium come from?
Before the actual
The presynaptic, part of the.
It comes from two places, either from the transporters that are opened when the signal arrives, when the electrical signal arrives, or it comes from the prepackaged from the endoplasmic reticulum.
Well, actually, probably, this is pathology, I put a reference for you here. All right, so where does the calcium come from? Why is it important actually for that? It is important because. All right, one great book you may refer to always is called Rapid Review Pathology. Rapid Review Pathology, if you're familiar with that book. This is a book that reviews everything. So instead of actually going and reading anatomy from one place and then reading genetics from the second place, and reading pathology, this book is all basic science in one. And this is actually from Rapid Review Pathology. So what I want to tell you here actually is I'm just looking for the name. Yes, it's called voltage gated calcium channels. Right. For voltage, so the calcium would come from voltage gated calcium channels. And those are actually located near the sites where the prepackaged acetylcholine is situated. Okay? Now, why am I actually bringing this up? Because there are also autoantibodies that are directed against the calcium, gated channels, the voltage-gated calcium channels. All right, and when those actually autoantibodies go after, those gated channels, what will that result in? No calcium being secreted, right? So as a result of that, there will be weakness here as well. The weakness here will be due to a disease that is happening in the presynapse. All right, what do you call that syndrome? Eaton-Lambert syndrome. Where does it happen?
Presynaptic.
Where does it happen? In what patients?
Small cell lung cancer.
Lung cancer. What kind of lung cancer?
Small cell lung cancer.
Small cell, right? Small cell lung cancer. Very good. You guys, you know it all, obviously. Yes. So, here's one thing actually. Once those calcium channels release the calcium, those vesicles are going to fuse with the presynaptic membrane right here. Okay? And they are going to release their content. Okay? Now, each one of those vesicles has about 8,000 to 12,000 molecules of acetylcholine. That's what you call the quanta. All right, and that's a lot of actually acetylcholine per vesicle. Okay. Now, once actually once those vesicles are released into the this area right here, into the synapse, the presynaptic, everything is recycled in the body. There's nothing that will be thrown away. So the presynaptic end is going to retake those actually membranes by phagocytosis, and it's going to work them up, and it's going to re-feed them with acetylcholine, waiting for the next nerve impulse. Now you have actually, so the acetylcholine now is in the synaptic, space right here. Like I told you, the synaptic space is two parts: the primary synaptic cleft, if you want to call it, and the secondary one. Now, the secondary one is very rich with acetylcholine esterase. And what does acetylcholine esterase do? It breaks down acetylcholine, right? And why does it do that? To stop the neurotransmission, so the neuromuscular transmission. Why? So that it will reset the muscle, so that it will make it depolarized again when the next nerve impulse will arrive. Okay. Now this is one strategy that is used to treat myasthenia gravis by giving actually choline esterase inhibitors. Okay. Because when you give choline esterase inhibitor, what happens to acetylcholine level? It will rise.
Yeah.
So that's going to result actually in neurotransmission, because it will go into the muscle end, and it will allow for the depolarization. Now here's one thing actually. If you have so much of this acetylcholine available, that is going to sensitize the receptors, the acetylcholine receptors. And what would that result in? So that's going to result in further weakness. What do you call this crisis, quote unquote? Cholinergic crisis. So the use of the choline esterase inhibitors is going to increase the amount of acetylcholine, and that's going to result in overflooding. The receptors will become desensitized, and that's going to result in further weakness, and that actually condition is going to be called cholinergic crisis. Is that clear?
Yes.
Okay. So right. So now actually you can see also, so we have talked about the presynapse. We have talked about actually the synaptic cleft. The primary synaptic cleft is about 70 nanometer in width, and it has the length of the presynaptic motor nerve. Okay. Now, as you can see, it does not have any lateral boundary, so it communicates with the extracellular matrix. All right, and you can see actually that the sites of the release of the acetylcholine are in direct juxtaposition to the folds actually of the postsynaptic muscular end. You can see that, right?
Yeah.
So you can see so that when it, and why is that the case? Because those actually those bases of those folds, which is what is present in the postsynaptic muscular end, those folds have what you call a very narrow stop and very broad base. And the broad base is where you see the maximum concentration of the acetylcholine receptors. And it makes sense that actually the areas where the acetylcholine will be released is going to be just directly across, the river, if you will, from the place where the highest concentration of the acetylcholine receptors are present. Okay? All right, so this is in a nutshell what happened here. Did I forget anything? No, now let's talk about the acetylcholine receptors. Acetylcholine receptors, that is made up of actually, of 5 subunits, 2 alpha 1 units, 1 beta unit, 1 delta unit, and 1 sigma unit. This is in an innervated nerve. In a non-functional or immature nerve, you will see that this unit here is replaced by a gamma unit. Okay? Now, how does it work? When the 2 alpha units are occupied by acetylcholine, the acetylcholine receptor is going, actually, I apologize, this should be acetylcholine receptor, so you have to add here an R, my apology. So the acetylcholine receptor is, quote unquote, going to open like a Chinese purse. For the girls here, do you know what that means?
Yes. Like the coin pouch?
The coin what?
The coin pouch?
The coin what?
Pouch.
Couch.
Pouch. Pouch.
Pouch.
Yeah.
Okay.
Is that the Chinese bag?
I have no idea. I was wondering, you have to take what they tell you. Slightly twist, slightly like a Chinese purse. The only way that I would think about it is that it will open like this. It will open like this. And when it does that, it will allow for actually the opening, the temporary, the transient opening of the acetylcholine receptor channel, which will allow for the entry of sodium, and that is going to allow for the depolarization to happen, in the muscle. All right. So I guess this Chinese purse, I'm going to leave it to your imagination to see how it happens. I cannot see. I can barely see from show me. No, just a second.
With the little,
Can you play, maybe put the play?
yeah, absolutely.
It's just like a little sun.
Save.
Anyways, I hope it makes sense to you. It did not make sense to you. Alright? Alright, now, if the number of the open sodium channels, reaches a threshold, you will see actually a self-propagating muscle action potential is generated in the postsynaptic membrane. Okay? Now, this is actually where some of the congenital myasthenic, syndromes that we have talked about, the fast channels or the slow channel syndromes are caused by abnormalities of ACHR channels. Again, there's not much, help here. All right. Okay. All right. So one thing actually I want to tell you about right here. That's actually a very important thing to know. Why does the weakness happen with repetitive movement in myasthenia gravis? Okay. So just coming back to, so with the nerve impulse, a large number of vesicles release acetylcholine in contact. This produces a large depolarization, is known as the end plate potential, EPP, of the muscle membrane, leading to propagated action potential and muscle contraction. Now, during repeated, in normal condition, during repeated actually nervous stimulation, the amount of acetylcholine released progressively decreases after the initial few stimuli. That is called synaptic rundown, which is normal. But even with synaptic rundown, if the acetylcholine receptors are normal in quality and normal in quantity, this synaptic rundown will not result actually in weakness. There will still be an EPP happening. Okay? Now, what happens actually in patients with myasthenia gravis is that they have less numbers of acetylcholine receptors than normal. And as a result of that, that is coupled with the synaptic rundown, that's going to result actually in increased weakness with, or progressive weakness with repeated contraction or the repeated movement of those muscles affected by the disease. Did you guys get that?
Yes.
You did not get that? Okay. How can I actually, it's a very tricky thing, and today I find out about it really. But I had a question, believe it, from my years of postgraduate training, and today it made only sense about actually this weakness. So what happened here again is that you have a residual capacity, meaning 10 will actually fire will result in depolarization of the postsynaptic muscles. 10, let's say 10 acetylcholine will actually result in firing or in the contraction in the postsynaptic muscles, and 1 will also do that. 1 acetylcholine molecule. This between 1 and 10 is what you call the safety factor. Okay? So if you go from 10 to 1, you're still going to get a contraction. Similar to the one that you get at 10. All right? But in patients with myasthenia gravis, having lost the ACHRs, the receptors, okay, or in the one of those, congenital syndromes, the fast channel syndromes or the slow channel syndromes that have a problem again. Now in this, in those actually are problems not with the quantity but with the quality of the ACHR. Then going from 10 to 1 is going to result in, unlikelihood of the depolarization to happen, which means actually that there is muscle weakness or inability to contract. Does that make sense to you now?
Yes.
Okay, good. All right. Okay, so what happened as a result? So this is actually a schematic drawing of what happened in a neuromuscular that got affected by, the myasthenia gravis. You can see actually that the number of acetylcholine receptors have decreased, correct?
Yes.
Because of the
Number
antibody.
1. 2, the synaptic cleft, the primary synaptic cleft has increased in size, correct? Because of the fact that we no longer have this, this high folds in the postsynaptic muscular component. You can see actually that the cleft, the secondary cleft are now what? Broader, right? The synaptic cleft are broader, and the synaptic, the postsynaptic folds are narrower, correct? Again, as a result, or flattened, postsynaptic folds. Remember that? It used to be much actually broader here. All right, and now it is much narrower, much narrower than before. So these are findings that you can see as a result of the myasthenia gravis autoimmune attack on the acetylcholine receptors. All right, so how does the ACHR antibodies do the trick? They may actually go and combine with the ACHR. So the autoantibodies will go cross-linked with the ACHR, and then they are going to be, that can result in accelerated endocytosis and degradation, by the muscle cells. Or it may prevent the combination of the acetylcholine with the ACHR, simply blocking the ACHR. Or actually it may result in complement-mediated destruction of the ACHR. Now there are a group of patients where actually there is no anti-ACHR antibodies. That's actually the classic anti-ACHR antibodies that we know about. Those patients with, in a subset of them, not all of them, but in a subset of them, in about maybe 10% of them, we see different set actually of antibodies known as the anti-MuSK antibodies. So what is the anti-MuSK? So MuSK is one of the proteins that is involved in the anchoring and the clustering of ACHR. So clustering it, if you recall, right here. Okay, so the cluster that you see here is done under the supervision or with the help of the MuSK protein. So when you have actually an anti-MuSK antibody directed against it, what will happen to this? That's going to actually be, destroyed and separated, and that's going to also end up, as in weakness, similar to what you see with anti-ACHR. Okay, so if it's not the anti-ACHR, then you may actually look for anti-MuSK before you actually say that I don't have the autoantibodies that are that could be the culprit of that disease. Now, even after you do the anti-MuSK, and found out that it is negative, there is also unknown antibodies to us as we speak now that maybe actually are the responsible autoantibodies for this disease. All right, now we know that there is also a role of the thymus, and this role has been known for about 200 years. So thymic abnormalities are found in about 75% of patients, the majority of which with germinal hyperplasia, about 15% with thymic tumors including thymomas. So how does that happen actually? It was found that inside the thymus itself, there are muscle-like cells, what you call myeloid cells, with the following, with ACHR on its surface. How about that? And near them, there are T cells and also antibody-presenting cells. So this is actually where the autoantibodies to the ACHR are being produced inside the thymus. This has been confirmed, in a lab. There are other hypotheses, about the role of the thymomas, that you see in patients with myasthenia gravis. Considering molecular mimicry, that is an immune response to an infectious agent that resembles the ACHR. Now, the diagnosis of MG is what you guys are going to be doing, which is the clinical diagnosis. But you need to confirm this diagnosis with lab tests. Why? Because once you actually, give the patient this diagnosis, this patient is going to be on medication for the rest of his life. That's the only way to do it. Now, that's actually may not be so bad because at one point in time, you will see that, this disease used to, in ancient time, used to kill. Nowadays, with the advent of therapy, the mortality ratio, the mortality number is probably 0, but with long-term treatment. So you need to actually make sure that your patient does actually carry this diagnosis before you label them as such. How do you do that? You need to actually run the lab test, looking for an antibody against ACHR. This is why it is so important actually to know, that there is, those against ACHR and those against MuSK. And do also some neurophysiological tests. Some of those tests are actually what you call a challenge test, and it has to be done in a room that is equipped with cardio resuscitation because it may result in cardiorespiratory failure. Excuse me, that is the Tensinet test right here. So you only do it actually under certain conditions. There is a long list, as you can see here. You're going to be taking this again after reading the clinical lecture. You're going to be taking that in the clinical lectures. Let's not go through it now. There's also a long list of medication, again, not claiming to be giving you the management, whether with regard to diagnosis or with regard to treatment, but just what you may actually think may be used. Anything that is immunosuppressive is going to could be used in this disease, including corticosteroids, immunosuppressants. The antibodies are actually in the plasma, so you may as well remove it. This is what we used to do to those patients who used to present to the transfusion medicine service. You actually put them on a plasmapheresis machine to remove the autoantibodies. The intravenous the IVIG may be also there. Thymectomy has been shown to be actually working in some patients, not all, but in some patients. Now, myasthenic crisis, this is, the extreme, phase, of this disease, or the extreme spectrum of that disease. Where does it happen? Usually, accompanied by infections or inadequate treatments, and those patients have to be managed in intensive care unit. Why? Because of the risk of cardiorespiratory failure. And here you need to actually use everything at your disposal in order to bring back the patient, from this care. Prognosis of myasthenia gravis, for untreated, it could be deadly. But this is highly unlikely now. In the West, it does not happen at all. Modern treatment prognosis actually with practically zero mortality. So most patients live normal life. That is actually with treatment. And those patients, with thymoma, particularly the patients will carry actually a worse diagnosis. If you recall, there are two peaks of the disease, one in young and one in old. This is actually the same with a lot of other diseases. Always the disease that happens in older age will carry a worse prognosis than when it is happening in the younger population. Here and everywhere else. That's it. Told you, short and sweet. Go ahead.
Thank you.
In case of myasthenia
Speak
gravis,
up, please.
Associated with the thymoma, isn't it that after the resection of the thymoma, isn't it gonna disappear?
Is it gonna what?
Isn't it gonna disappear? The symptoms.
Disappear?
Yeah, after the
Yeah,
resection of the
may, like I said,
So
it
why
may
it's
result in reduction. But, in a good number of patients that have good thymoma, it was shown that having thymoma is, or, note or denote a poor prognosis.
So
That,
it's not
that
that.
treating the thymoma may cure in certain conditions. But in the